Okay, so good afternoon, everybody. And today we are going to talk about some very interesting case journals, which is going to be discussing about key aspects of pediatric endocrinology. We have got three major review articles which we'll discuss, and then I'll focus about four new interesting ideas which have come up based upon research recently. So our focus of Journal Club today is going to be one would be with regards to the effect of adiposity on insulin resistance and the overall conundrum of diabetes, which we've been discussing about. Then we'll touch base about some advances in terms of precautious puberty management, wherein we now have a longer acting analog than the conventional one, and the impact and how do we monitor that. Then I'll talk a bit about some recent studies which have shed light about the correlation of ovarian and uterine size during mini puberty. An interesting article about how infants sleep has an impact in terms of their height, then the role of somapacitan in SGA children. So we'll discuss briefly. That will be like a very quick flash in that regards. So first of all, of course, we all do have to do a literature review and follow the literature because there's a lot of changes which keep on happening in terms of the literature. And if we do not keep a track of that, there will be a problem. So why do we do a literature review? Of course, we want to change our practice. But before we change our practice, we need to know whether this article that we are really reading is worth changing our practice or not. So we need to understand about whether the article is valid in terms of whatever they have found is something which is close to the truth. The next, of course, issue will be that suppose this is valid and whether it is applicable to our setting or not. So if we have some intervention which is not possible at our level, so somebody tells you that you have teplizumab which is available, which can increase the latency of the diabetes by a few weeks, you would say, okay, but then the cost is prohibitive, it's not available, then it may not be generalizable to our population from that regards. Now, whether this represents a novel work and whether we should really change our practice or not. So we'll try to put these three papers on test and how they can change our practice and how they can improve or in that perspective. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of resources and courses related to pediatric endocrinology. We have got a fellowship course and a diploma course. We do run a number of grand rounds, postgraduate lecture series, and journal clubs to highlight pediatric endocrinology. There are multiple publications which are available and the mobile application which really helps us guide in terms of evaluation. So our three major talks today are about the role of body fat and insulin resistance. Then we talk about long-acting GnRH analog and unstimulated LH in terms of monitoring, because that's one area in which there is always debate about that. So we'll start off first with our talk on the role of fat mass and how it really can correlate with regards to the development of insulin resistance. And we will invite Dr. Dhwani to talk about that.
Thank you, sir. So this paper looks at DEXA-based fat mass with risk of worsening insulin resistance in adolescents, and this is a prospective 9-year temporal study. Why do we need the study? Is because as even in the predictors of metabolic complications in obese children that was done at our center, we found that almost as many as 40% subjects are free of any metabolic complications, despite obesity becoming more prevalent in the last few years. And our study shows that children with obesity who were picked on screening for dysglycemic complications had a better outcome in terms of who went on to develop type 2 diabetes. So what we need to know, or where our lacuna lies, is we still don't know the factors predicting dysglycemia in children and who is more at risk. We don't know what should be the ideal age at intervention, even in the absence of complications. So even on screening, if we find no complication, is there any other surrogate marker that could guide us about the risk of developing dysglycemia at a later age? And if there is a certain age, what should be our target of treatment, or how aggressively should we intervene in them to prevent long-term dysglycemia? And this is something that the paper has probably tried to understand in terms of it is looking at the body fat percentage to estimate your long-term risk of insulin resistance and dysglycemia. So how it was done is it used the ALSPAC cohort, which is somewhere around Bristol. So every delivery that was happening around there, uh, the children or the mothers were enrolled at the time of delivery, and these children were then later followed up at 15, 17, and 24 years, at which ages the DEXA scans were done. Along with fasting glucose, fasting insulin levels, and insulin resistance. Fasting glucose more than 110 milligrams per deciliter was taken as hyperglycemia. Fasting insulin greater than 11.7, it was again a marker of hyperinsulinemia in these children. And a HOMA-IR resistance of greater than 75% was considered significant, whereas less than 75% was considered normal. While we know that HOMA-IR is a surrogate marker of hepatic insulin sensitivity, there is another SPICE index which takes into account cholesterol levels as well, and it has been used as a surrogate marker of whole body insulin sensitivity in this study. So the correlation that it has seen with several clinical parameters is the insulin resistance, again, as you would expect with increasing BMI, your insulin resistance will increase. However, the whole body insulin sensitivity did not match very well with the clinical parameters in this study.
Just one second. So, HOMA-IR is a marker of insulin resistance, and SPICE is a marker of insulin
whole itself, yes.
So it's the
Okay.
opposite. So when
Yes.
you are saying it's minus 0.9, what you're basically trying to say is that if your BMI is going up,
It will, sorry.
your sensitivity is going down. So it's actually showing a very good correlation. Because it's a negative correlation, but then it's the other way around. So what you're looking basically is that there is a moderate correlation. I'm sure the P will be significant. You're having in the numbers.
Numbers of?
Number of the children.
3,000.
So it is a large study,
190.
so 0.37 would be a big number as far as correlation is concerned. But minus 0.9 is much more significant.
Yes.
So I think that's something which gives you, which is expected. That as your BMI is going up, your SPICE should go up. But what's not expected is the
Lean
last
mass.
one. How does the lean mass have a negative correlation? So just by using cholesterol, they are adding cholesterol into the IR, HOMA-IR.
So they've not used HOMA-IR. It is a complicated equation which takes into account the triglyceride, LDL levels, and BMI.
Okay. Which I think is a probably might have been validated somewhere, but I will be very questionable about that. But just by looking at lipids, how can you talk about that this is something which is a marker of whole body sensitivity? So that will be with a pinch of salt. What do you think about HOMA-IR as a marker of insulin resistance? What is HOMA-IR?
It is looking at your fasting glucose and fasting insulin levels, and based on that, it is trying to estimate the amount of insulin required to maintain.
So it's basically what it's trying to say that this is your fasting insulin and this is your fasting sugar. So then people will say, okay, if my fasting sugar is high, my insulin should be high. And then you try to see how much is the correlation in that. So it's a crude marker. What is the best marker of insulin sensitivity?
So hyperinsulinemic clamp test maybe a better.
Basically give insulin from one side. You give glucose from the other side. So you have two options. You can give either a euglycemic, hyperinsulinemic clamp. You want to maintain sugar 100 to 140, or a hyperglycemic hyperinsulinemic clamp. Both of them will give you the idea about insulin sensitivity, rather a disposition index, which will give you a good idea from that regards. So HOMA-IR as such a tool is not a good tool for patients. So a lot of people order HOMA-IR. It is not recommended. Fasting insulin and HOMA-IR is not recommended on routine clinical practice. You can use it as a research tool if you're looking at intervention or a large 3,000 patients. You can't do an insulin clamp, of course. So that's why you are doing HOMA-IR. But I would be a bit wary about that, although it shows a very good negative correlation with your BMI, trunk fat, and total fat mass.
So they also looked at the clinical parameters to take into account the environmental and family factors which may contribute to the dysglycemia and insulin resistance. They took into account the family history, At the very first visit itself, 15 years, it said they took the history of smoking and alcohol exposure and quantified it in terms of the magnitude of exposure. They also looked at the socioeconomic status of the mother, because this is basically a 3 generational study that they're looking at. So it starts with the mother. Currently, the phase that is going on is the second generation, and it plans on looking at the third generation as well. And the physical activity levels, which were again taken at 15, 17, and 24 years. They used an accelerometer initially in the form of a band that was worn for 7 days, which quantified their intensity of physical activity and the sedentary times. And at the 24-hour visit, they used a band that was worn around for 4 days. So what they found was, so as you can see already in the 15, 17, and 24 years data, they started out with 3,000 patients, which by the 24-year visit were about 1,700 subjects that were followed up. As you can see, the trunk fat mass were higher in females in comparison to the males at each of these ages. With increasing age, the fat mass increased.
So, Dr. Sandeep, do you think this is unusual? The fat mass being much higher in women. Yes. So, do you expect that? Is it normal or abnormal? Fat mass is more. So it's around 1.5 times higher as compared to boys anyway. So what we are saying is that it was 8 and 17. So it is something like 1.5. And what is definitely more is that trunk fat mass is the one which is more. So this is something in the expected line. So if you look at our own reports, we say 20% is the upper limit of fat mass in young adults, males, and maybe up to 30% may be normal in females. So this is what it is fitting into.
And as one would expect, again, the lean mass was significantly greater in males in comparison to females, and again, it went on to increase with age.
But something is telling you that the girls had a higher prevalence of, were more adipose, besides this common physiological variation, which is that the BMI was higher, the chances of having obesity was higher, especially in the younger age group. 15-year and 17-year girls had a higher prevalence. After that, it tended to be same.
Yes.
Carry on.
Again, the prevalence of smoking was found to be greater in females in this cohort initially, which went on to become equal in boys and girls eventually by 24 years of age. Sedentary time, again, as probably one would expect, was more in the females in comparison to the male initially in the 15 and 17-year age group. And then the gap tended to fill.
But when you say it is significant, it is 353 minutes versus 361 minutes. So this is just because your sample size is huge, you are getting that difference. So it is statistically significant, but when you are saying it's like 6 minutes, when somebody is actually sedentary for around 6 hours, so this 6 minutes will be like less than 1.5%. So I would not be that much bothered. They are similar in that regard.
And again, the moderate vigorous physical activity time was greater in males.
This we can say this is like 25% more. So this will be clinically significant also. So in general, your impression is that the girls were less physically active.
Yes.
They were having a higher tendency of having obesity. These two things I think probably is coming out. Any differences in terms of the other parameters like insulin sensitivity? They were all same.
We will come to that. So what they found out was that the total fat mass, I'll first start off with the graphs here. So what it shows is that your fat mass slightly increases from 15 to 17 years of age, but beyond that period, it will rapidly rise, especially in boys in comparison to the girls. The lean mass was again fairly slow progression that was seen in the study cohort, and because of your rapid increase in fat mass from 17 to 24 years, you can again see that your insulin resistance, which had dipped at 17 years, went up again.
So why do you think insulin resistance dipped at 17, Vibha? Yes, so it's gone down, but what they are showing is very good that after that you benefit because you're gaining weight, you are again going up. So that is something which they are showing in that regards here.
So what it shows is your total fat mass at 15 years positively correlates with an increased risk of fat mass at 17 and then again at 24 years of age. And total fat mass at 15 years was again positively correlated with your risk of insulin resistance at 17. And it was also vice versa true, where your increased insulin resistance correlated with the further increase in fat mass.
But these are all univariate analysis.
Yes.
These are not corrected correlation. Or
Correct.
partial later on, but this
Later
is just the initial
Yes.
data.
Yes.
So yes, so what you're trying to say that if your HOMA IR is more at 15 years, you're more likely to be obese at 17. But the reason is your HOMA IR is more at 15 because your total fat mass is more. And that is persisting.
Yeah. And the only thing is like total negative correlation here because again at 17 things are dipping. Your fat mass.
And this is not significant. 0.0. Yeah, it's not significant. So let's just explain it.
Sorry.
So what you're trying to say essentially is that if somebody is fat at 15, he is likely to be fat at 17 and 24.
Yes.
There's a persistence which is there. If you have HOMA, if you have insulin resistance or your HOMA IR is high, you will continue to be the same.
Yes.
So there's a trend which is continuing in the same. Now, if you talk about cross linkages, you're saying that 15 years is predicting 17 HOMA IR and 17 is predicting 24.
Yes.
This is what you're looking at. So basically, if you if you just summarize in one thing, if you are fat at 15, what does it mean?
That your risk of being fat at 24 is higher and your risk of insulin resistance at 24 is also higher.
I think the most important thing is that you don't want people to be obese at 15.
Yes.
15 seems to be a time when it's been imprinted. And after that, it's going to continue from there. Yes. And then they don't have the earlier levels because I think 15 is a bit late. They should ideally have put into somewhere around pre-pubertal age group and then maybe mid-puberty because 15 is mostly post-puberty. So in that scenario, you will have confusion. That's the reason.
So this is again the cumulative body composition, and model 1 is the uncorrected one. Model 2 has been adjusted for sex and model 3 is adjusted for sex and all other parameters, physical activity, your lipid levels, CRP levels and all that. So what it tells you is again, as your total body fat has an odds ratio of 1.04 with risk of hyperglycemia through ages 15 to 24, hyperinsulinemia as well as insulin resistance. More importantly is the truncal fat marker of central obesity, which is again shown an OR of greater than 1, suggesting a positive correlation. Lean mass, as one would expect. So lean mass has shown an odds ratio of less than 1 for elevated insulin resistance and hyperinsulinemia. However, it is still positively correlated, just 1.01 for hyperglycemia was what they found. And BMI showed similar results to the total body fat and truncal fat mass.
So if you have, so what you're trying to say is that if you have got more total fat, more truncal fat, more BMI, you have more insulin resistance.
Yes.
Essentially. And lean mass is less important.
Lean mass is protective.
But not to that extent.
Not to that, yes.
Like 0.98, just on the range of it. Now, if you look at it, which of the parameter is the best predictor?
So BMI looks like the best predictor.
So I think that is of all the things that we talk about, body fat. So these are actually fat mass related by DEXA.
Yes.
So what it comes back to the whole story is that the BMI is the best marker. If you look at the odds ratio, it's 1.26, 1.19, 1.07, against 1.04, 1.09, 1.12. So I think ultimately that's what we have also found, that BMI is the best marker. We don't need to go into all that fancy things like trunk mass, total fat mass, and maybe BMI or fat mass is more important than lean mass.
Yes.
So while you want to increase your lean mass, focus should be more to decrease the fat mass. That would be the major scenario in that.
Again, because they found a positive relation of lean mass with some increase in the dysglycemia and HOMA-IR, they tried to explain it with other parameters, and they found that high lean mass also had a background of high fat mass, which probably contributed to the
which decreased the
decrease the
beneficial
impact
impact of lean mass.
And similarly, they also correlated the effect of triglycerides and LDL-C, which also seem to have which seem to decrease the impact of lean mass on HOMA-IR.
So what they're saying is that lean mass is having an effect on LDL, and that LDL is having an effect on that. So it's the pathway analysis. Basically, they're trying to look at whether there's a confounding factor there or not.
So I think the major lesson that we learned from the study is that fat gain was rapid after 15 years, 17 years. So although they start off with obesity, if it persists beyond 17 years, the magnitude of impact may be higher. Overall, in the study, the greater impact was seen on the boys in terms of gain in fat mass after 17 years, and that is something we need to look at. If we intervene at 15 years, long-term benefit is expected if we go by the results of these study. And again, what has emerged importantly is that BMI is a fairly accurate surrogate of body fat mass and may be a good predictor of risk of dysglycemia later in
I
life.
think the main message here would be that probably they missed the bus. They missed the bus at 15 because at 15, your BMI is going to go down slightly. But if your BMI is less than 15, then that decrease will be much better. So if you want to design a school study or a school education, what would you like to do in that regard?
Probably look at children by 10 years of age to see if before the onset of puberty.
Anybody is obese pre-puberty, they are the most likely to benefit from the intervention. And then beyond mid-puberty, it will be difficult. So you want to start intervening from around 10 years and look at BMI. Don't do all the DEXA and everything. You don't need to do insulin sensitivity. But if you are able to decrease their BMI during puberty, so that by the time they are 15, their BMI is already less, then you will be able to achieve a better outcome, because after 17, whatever you do, your BMI is increasing. That's what they are showing.
So again, this was a prospective study. Like Sir said, it used the parameters of HOMA-IR and SPICE. SPICE is again an upcoming index. It needs greater validation in pediatric population. And probably instead of HOMA-IR, a hyperinsulinemic clamp
Not possible. Nobody can do that thing, because that requires admission, you have to admit, give it. So it's not possible for a population study.
And the population it looked at was all white population, Caucasian population. So if you look at the generalizability, it does not take into account Asian population who have a greater risk of truncal obesity. And I think the diet of the population was fairly homogeneous in our country because of the greater variability. It may have an impact on the risk of dysglycemia. And the impact that has emerged is that total fat mass and BMI are fairly good indicators of long-term risk of developing dysglycemia.
So I think if you say that total fat mass is also a good marker and BMI is doing better,
so
then it's a very, very clear message that there's no use, because for total fat mass, you do a DEXA.
Yes.
Now, how do you do a DEXA? The children will have to come to the hospital because it's not a portable machine. So I think whatever we have found and whatever they are showing also is that BMI is the best parameter. Don't worry too much about it. And waist circumference is the waist. This is what is emerging from many parameters of studies.
So again, total fat mass at 15 years showed a positive correlation with your long-term risk of insulin resistance. BMI emerged as a fairly accurate indicator, and probably we need longer follow-up to see how many with insulin resistance actually went on to develop a dysglycemia, and what age did the dysglycemia start in this specific cohort.
What is your experience? When does dysglycemia start?
At onset of puberty is what
So
we've
we have
seen.
seen children around 10-year, 9-year also. So this is actually something which was done very late. So I think the best strategy, as you said, we can probably start up right from 5, start monitoring. If somebody is falling off the chart by 8, 10, we have to start intervention. Because otherwise things will start happening by that age. How many of them actually had dysglycemia at 15 years? Did they mention that?
Yes, they have.
Play. You have to go here, that side, and then select this. No. Select the slide.
Oh.
Select this one.
Right. Okay.
So they are saying that hyperinsulinemia, hyperglycemia was present in a few cases. Hyperinsulinism was actually present in 19.7. So that was a significant number, but that again, I won't be too much bothered about. The dysglycemia was around 1%. So that was a very, very low prevalence. So I think that's a very good study, which really tells us three things. What I'm going to summarize there is that we are basically looking at in terms of scenario of people who are getting overweight and obese, and the right time to pick up would be much earlier than 12 years or those in that regards. So we have discussed this about with regards to the overall parameter of the impact of fat, body fat and insulin resistance. We now move forward to the second study. We all have been using GnRH analogs for quite some time. And we have been, initially it was available as a daily injection, then it was available as a weekly one, then it became 4 weekly, now we are using 12 weekly. There is one which is a yearly injection which is available. Now Dr. Vibha is going to shed light about this new long-acting GnRH analog, which is going to work about in terms of 45 milligrams. And we have a follow-up paper also on a similar ground, which Dr. Sandeep will talk about.
Thank you, sir. So I'll be discussing about this newer long leuprolide acetate that they have used 45 milligrams 6 monthly subcutaneous. Its treatment and its treatment use in monitoring. So the paper has been discussed, the why study is being done, and how they have done the study, and what were the results, and what this study will have the impact on the clinical practice. So we all know that during the treatment of the precocious puberty, we all need to monitor the patient. We do it clinically, and when there is a discordance between the laboratory values and the clinical parameters, we often go for the GnRH stimulation test. And the study says that this GnRH stimulation test should be done in each and every patient during this treatment part, because it helps in to verify the adequacy of suppression of gonadotropin secretion. So we generally use leuprolide acetate subcutaneously with a dose of 20 microgram per kg, and the another one is tiprolin with a dose of 100 microgram subcutaneously. So the study has used leuprolide acetate of 45 milligrams 6 monthly, and it was given subcutaneously. The main question, they have postulated that the therapeutic subcutaneous leuprolide may also be used to monitor the response in the central precocious puberty in place of a traditional GnRH stimulation test. So they conducted a study on the basis of this hypothesis. And the main question, why they have used this therapeutic treatment as a for the monitoring, not the traditional GnRH stimulation test, because GnRH stimulation tests are not practical, they are often expensive, and the child have to give an additional injection for the monitoring, which give a negative impact on the clinical experience of the child. And the parents have to give extra time for this stimulation test, and it bothers the family and the children as well. So that's why they found that the using this treatment part for monitoring will be good for both the families and the children. And the study was conducted on the basis of this non-published data of this small study, where they have used a small volume of subcutaneous leuprolide acetate for the treatment of central precocious puberty. And the data was used from this study. It was a phase 3 multi-center study, open label, and a single arm study. There was no control arm. It was conducted between August 2015 to September 2018. And 25 sites in 6 countries were involved in the study. And they have given subcutaneous leuprolide of the dose of 45 milligram at the interval of 2 weeks. They have given 2 doses and have seen the response. The study population included 60 children with the girls of age between 2 to 8 years and boys 2 to 9 years. They were the confirmed cases of central precocious puberty. And the diagnosis criteria, the confirmation of precocious puberty was based on the clinical evidence of puberty, which was defined as if the pubertal stage of breast stage more than or equal to 2 was present in girls and testicular volume of more than 4 ml. And if the bone age was advanced by at least 1 year with as compared with the chronological age, and if the pubertal LH response was more than 5 international unit at 30 minutes subsequent to GnRH analog. And they excluded all the peripheral precocious puberty cases, non-progressing, isolated premature telaki, previous seizure, or any chronic illness. And for the confirmation of the diagnosis, they have used the leuprolide acetate via subcutaneous method with a dose of 20 microgram per kg. Now, during the study, what they have done, first they have made the clinical diagnosis, and they have screened and monitored the patient during the treatment at 12, 24, 36, and 48 weeks. And they also collected some samples for random LH and FSH and estradiol at 4, 20, and 44 weeks. To evaluate the pharmacokinetics, as it is a newer drug, this 45 milligram is quite a huge amount, and to check its pharmacokinetics, they have collected the samples at 1, 6, and 1, 3, 1, 4, and 6 hour, and they have set the cutoff for adequate suppression to prepubertal levels, that was LH less than 4. And in the results, they have found that after given this leuprolide acetate of 45 milligrams subcutaneously, the LH level, there was an initial surge in the first 4 hours. As we can see that it was a surge of around 40 international unit. Then it very well correlates with the serum concentration of the leuprolide. Then it becomes stable. And if we see that they compare the GnRH stimulation test and this 45 milligram 6 monthly dose, what they have found that there was a suppression in both the cases, which was less than 4, and this 45 milligram was given at a 24 week interval. And if we can see the black line, it was between the 1 or 2, I would say, the LH level was below 1. And if we see the GnRH stimulation, post GnRH stimulation, the level was below 4. It was around 3 international unit per liter. So on the basis of this, we can see that it is this 45 milligram leuprolide acetate with the dose of 45 milligram given at an interval of 24 weeks is equally sufficient in suppressing the LH levels, as well as it has a rise after within the 4 hours. They have also compared this leuprolide acetate with the traditional GnRH stimulation. As we can see in the first 2 studies, where the 7.5 milligram monthly dose IM and 3.75 milligram monthly dose IM was compared with the traditional one, and they have seen that the peak rise was equivalent to the traditional GNRH stimulation test, and the suppression was also less than 1 in both traditional and the this 7.5 and 3.75 milligram leuprolide acetate. And if you see on the last column, the where they have used the 45 milligrams leuprolide acetate given 6 monthly, it has shown the similar result with a rise in the LH levels more than 40, higher than the traditional GNRH stimulation. But it has this study incomplete because they have further studied it further and given the results of suppression. I would show in the further slides. They have compared the subcutaneous leuprolide acetate with the intramuscular leuprolide acetate, and they have found that both have showed the initial burst within the first 6 hours, as was shown in the graph, and the concentration decreased and remained stable for a while. The girls achieved pubertal levels of estrogen less than 20 after the second dose, that is after the 42 weeks, and the boys achieved the pubertal levels at 36 weeks. So if I conclude the study, it has shown that as compared to the intramuscular leuprolide acetate, subcutaneous also yields a similar burst release of leuprolide and induces a similar rapid rise in the stimulated LH levels in response to the first dose. And it also has an adequate suppression of the sex steroids subsequently. If the therapeutic dose of 45 milligram, if it is given at 6 monthly interval, it will be easy to monitor the treatment efficacy, and it will provide more flexibility and the utility, and it will be more cost effective and easier than traditional GNR testing for the patient and the family.
Subcutaneous, there are other studies also about subcutaneous leuprolide use earlier.
Subcutaneous, intramuscular, no sir, this is the first one for the subcutaneous.
Centers which use subcutaneous as well. The only concern is about subcutaneous, the volume may be a bit more.
Yes.
So that is the only concern which
they have used the data of the.
But many people, even with the current preparation, use subcutaneously.
Yes.
Because they say steroid abscess is another thing, the
less likely to be.
The concern basically is that one, it is a depot preparation.
Yes, sir.
So depot preparation, if you give it the muscle, it may store there for a longer time.
And
so did they mention any previous study of subcutaneous?
No, sir.
They didn't mention.
No. And they have only compared the intramuscular with the subcutaneous one.
What is the volume there?
0.675, very small volume. 0.375 ml they have used. Yes, sir.
That makes sense. But if you're giving 2 ml or something like that, as a
yes, sir.
It may be more difficult, painful, local
Yes,
swelling, other things will be there. So I think one big thing is that if you're giving subcutaneous, it will become much easier. In
and
terms of pain. And the second
frequency.
Did they mention about the 4 weekly or 12 weekly? Because a lot of people use that as stimulation test. Like we do not do a GNRS test, we just look at after 2 hours or 4 hours of that. So did they mention about that in those ones?
Sir, they have mentioned this tradition that was a Guzrelin.
No. What I'm saying is that
no, 12 weeks and
a lot of people do this.
No. They have not mentioned about this 12 weekly and 6 weekly leuprolide that we go for. No, they haven't mentioned.
So because routinely most people don't do a GNRS.
Yes, sir.
They will just use that as idea. What is the basis of using this injection of GNRH as a stimulating agent? So what is the rationale of their stimulation there? It's a long acting, so why will it stimulate?
Initially, because the initial burst in
Why? That initial burst is different. That is because of the flare response. What they're trying to say is that when you have a GNRH analog, some amount will be free. It will be rapidly rising. And that free part is what you're effectively is behaving like a GNRH. So that's what they're thinking.
Yes.
But then the issue would be whether it's really the same amount of that, whether the amount will be same for every injection. Some may have more free, some may have less free.
Yes,
but I think this is a good idea,
it could be
reverberates our idea that we can use it as a suppression strategy.
Yes, definitely. This study has a good impact will have a good impact in the clinical practices, because this the less monitoring is required as it is given 24 weekly intervals. So and it also reduces the additional injections. It has a very minor adverse effect like injection pain, rash, nausea, vomiting, which is minimal. And the similar therapeutic dose could be used for the monitoring as well as for the treatment. So it has a very good impact on the clinical practice. Yes, generalizability, it could be applied in the general population because it has no such side effects or variations. The children, it is advisable for the children with central precocious puberty, and the intervention is very feasible because this two injection has to be given for the for looking the suppression of the gonadotropins. The limitation of not this study, but the data from which the data the results is derived, they have used the peak LH after 30 minutes only. So for the treatment purpose, I would say this is the limited.
Have a more rapid onset of action, subcutaneous or intramuscular?
This intramuscular, this is deeper. So
Which will have faster. So if you want to look at
subcutaneous is
LH, yes, if you want
faster.
to look at LH after an IM,
Yes,
it
it will
will
take
take 2
time.
hours. 2 to 4 hours. But if you're looking at subcutaneous, it will be
40.
more rapid. Like we say, if the lantus you are giving, if the short acting you are giving in that intramuscular, you may have a different onset of action. Same.
And similar, there is a no long-term follow-up. They have just used 2 doses. And later on, they have not followed up. And there was also very low boys to girls ratio. So that's it. Thank
I
you.
think that's a very good presentation. Dr. Vibha has highlighted about main thing I think here is that we have a new preparation. Now it's not available here at the moment. Is it available routinely there? There also it's not available usually. No, you have checked it, is it available? Because the study you mentioned was much longer, earlier study. So we can check that about the availability because of course, if you can give it once in 6 months, it will be like much better. In that preparation, Hysterlin was once in a year, but that you have to implant. You have to make a cut and then put the thing inside. So that is a bit of a painful thing. And then the suture is to be given. If you give an injection 6 months, which is good enough. And if it's a very small, then it's something like denosumab, like what it's like a subcutaneous injection. So it becomes much easier. So I think the key messages which Dr. Vibha has clearly highlighted is that we have a new preparation which can be used once in 6 months. You don't need to worry about GnRH stimulation, and that is not required. You can just look at the LH levels after 30 minutes and you will get the idea. Now, the whole idea is when you are monitoring in terms of follow-up in terms of precocious puberty is whether you need to really go ahead with biochemistry. Because all the guidelines that are looking at, they are mainly saying that the clinical suppression is most important. And you need to look at the biochemical parameters only after your clinical suppression is inadequate. I see many patients in which the dose frequency is increased just based upon LH level. So what people will do, they will look at LH, LH is 5, they will make it 10 weekly, then they will make it 8 weekly. Don't go by numbers because that can be confusing. However, if you want to go by numbers, these numbers were validated by GnRH stimulation test. And we don't have access to GnRH. So don't use the same numbers every time. So maybe have an idea, but these are not the final deciding factor. And I think these points will be highlighted by Dr. Sandeep, who is going to talk further about these parameters, about how unstimulated. Now, the other issue that why worry about anything, just do an unstimulated level. And my general take was that when we did a review, is that random LH is of very limited role in terms of evaluation. So maybe this study shed some more light in that regards.
Thank you very much, sir. Dr. Vibha has already explained about the central precocious puberty and the role of this new drug, which is subcutaneous leuprolide acetate, which is given every 6 monthly. So in this study was conducted and published in April 2024. This was published in Hormone Research in Pediatrics. In this study, basically, they have the patients of central precocious puberty. They had 62 patients and they were given 45 mg of subcutaneous leuprolide acetate. Yes, sir. Yes, sir. Yes, sir. In this study, they are looking at the role of unstimulated LS, that is random LS, for looking for the suppression, sir. Suppression of pubertal progression.
What we are looking at is whether GnRH stimulation versus random LH versus
The clinical parameters.
stimulated versus clinical.
Yes, sir. Yes.
Or both studies if we come.
Yes, sir. Yes.
Yes.
So in this study, they have taken 62 children, and out of this, there were 60 girls and 2 boys. all the patients were already having central precocious puberty. They were diagnosed and they have not received any kind of treatment earlier. In this study, they received 2 doses of leucotriene acetate subcutaneous, which is a small volume of 0.375 ml injection given by subcutaneous route, and it was given every 6 monthly. The mean age in the study group was 7.5 years, and the mean height was 136.6. Velocity, mean height velocity was 8.9 centimeter per year, and the BMI was 18.6. So in this study, they initially found that at 24 weeks, the unstimulated LH was less than 1 in 84% of the children, and at 48 weeks, it was 86%. And at the remaining patients, the 8 children in which the unstimulated LH was not less than 1, but they had clinical features of pubertal suppression in the form of there was stable or decreased bone age to chronological age, and also the pubertal stages, that tenor staging was not progressive. So in all patients in this study, there was a pubertal suppression clinically, but unstimulated LH was 84% and 86% at 24 and 48 weeks.
So what they're saying is that maybe 14 to 16%
Yes, sir.
people had high LH, but that may not be clinically significant.
Exactly, sir.
That's what they're trying to say.
So they want to say that this LH level is of no significance without clinical findings.
This is what I was trying to say.
Yes, sir.
You may, it has no value. It doesn't help you.
Yes, sir.
What do you want in these parameters? You want LH to be more sensitive or more specific?
More specific.
More specific marker in terms of that. So
Yes.
that becomes important. So you're picking up everybody, but there's nobody who's progression. Now the big point is, when you say no clinical progression in 6 months, are we that good to pick that up?
No.
Do you think Vibha will be able to pick up very quickly, 3 months, 6 months? The breast development usually is very vague. It is usually the same. First dose, it may go up a bit.
Yes, sir.
Bone age is too early. So I think if you do this study over a 2-year period,
Yes.
3-year period, that will make more sense, which has already been done for the other preparation. So I think this is the same confirmation.
So brief about the study, the Pensolo is the brand name. It was given subcutaneously. The volume is very small, and it was given every 6 monthly, 45 mg subcutaneously. They did GNR stimulation test after administering subcutaneous leucotriene acetate 20 microgram per kg or the maximum of 500 micrograms at screening, and subsequently at 12 weeks, 24 weeks, 36 weeks, and 48 weeks. Blood samples for LH, estradiol, and testosterone were taken after 30 minutes of stimulation. And random samples were taken for LH and estradiol, which were taken at baseline, then subsequently at 4 weeks, 12 weeks, 20, 24, 36, 44, and 48 weeks. Relationship between the unstimulated LH and other endpoints like stimulated LH, the bone age to chronological age ratio, change in the predicted adult height were taken and were looked for the clinical correlation. In the children in whom the random LH was not less than 1, the GNR stimulated LH was not less than 4, and girls who do not achieve a estradiol level less than 10, but they were subsequently found to have a clinical parameter, were subsequently found to have pubertal suppression. So in this population, the main aim of study was to look for the role of unstimulated LH as an efficacy measure. In this study, they found that at 24 weeks, around 84% of the study group was having LH less than unstimulated LH less than 1, and at 48 weeks, it turned to be 86%. In the remaining children, though the levels were not less than 1, but they had clinical features of suppression.
When you say not less than 1, how high were the level? Did they mention that?
So it is in the subsequent slides. And ROC curve was plotted, and it was looking for unstimulated LH versus GNR stimulated LH. And at 24 weeks, the AUC was 0.88 and with a specificity of 88.7. And at 48 weeks, the AUC was 0.75 with specificity of 90%. Again, there was a positive correlation was found between stimulated and unstimulated at 24 and 48 weeks. These are the 10 patients in whom the random LH was not less than 1. We can see in these patients that at 24 weeks, the levels were like less than 10, less than 2 rather.
So maximum, there was one patient who was 5.6,
Yes, sir.
and one who had 3.3, 3.3. So it will be very difficult. I was thinking that if you can use a higher cutoff rather than 1, use a cutoff of 1.5 or 2, but that will not really solve the problem. The problem is that even those people whose LH is high, your stimulated one is also very high.
Yes, sir.
So which basically means is either your clinical assessment is wrong, or you need a much higher level of LH to cause those problems
Sure.
for progression.
But in all these 10 patients, there was stable or decrease in the channel staging, and also there was stable or decrease in the bonus to chronological release ratio. That means they had a clinical
Yeah.
regression.
So either the way you're using a gold standard is not good enough,
Sir.
or these values are of no value.
Sir.
Then both the studies, you don't need to do anything if you are stable. So what they're trying to say is that if your breast rate is increasing, or your BA to CA ratio is increasing, then you do all these tests.
Yes, sir.
Otherwise, you don't do it. And then it's a catch 22. If your BA and CA is increasing, and if your breast rating is increasing, you expect that their LH will be sky high.
Sir.
So then doing it won't make much help.
Sir.
Like if you say somebody has a POI and FSH is high, AMH will be low anyway. So because clinical parameters, by the time they change, you have already a lot of change in LH and baseline and stimulated. This is what it is coming up.
Yes.
Carry on.
And those girls whose stimulated LH was less than, they were not able to achieve that stimulated LH less than 4, but they five of those girls they had random LH less than 1, and all of them have a clinical separation. Those girls who were not able to achieve estradiol less than 10, all of them they had stimulated LS less than 4 and random
Which is
LS.
actually not, unless they have done estradiol using GCMS. Did they mention? GCMS.
And random LS less than 1, and also they had separation, clinical separation. The conclusion that unstimulated LH can be used as an adequate surrogate marker in lieu of stimulated LH in the children with CPP, along with the use of clinical parameters. So it can be used as a surrogate marker for stimulated LH, not for clinical parameters. All patients have a suppressed bonus to chronological release ratio, and the predicted adult height improved. Treatment had there was little effect on the BMI. And all those patients who were not able to achieve GnRH stimulated less than 4 and unstimulated less than 1 and estradiol less than 10, but all of those patients in the study, they had a good pubertal separation. So design was prospective. They used random LS to assess the separation. Population was 62 children who were already case of central precocious puberty. Subjects, the age group was 7.5, and it can be used in a large, in a different, the study size, we can increase the study size, and also the age group we can increase. The tests performed were unstimulated LH, GnRH stimulated LH, and estradiol. Impact, we can use this unstimulated LH in lieu of stimulated LH along with clinical parameters.
So why do you think they did the study?
So they wanted to use unstimulated, that is random LH in lieu of stimulated LH.
Or do you think that they were doing it as part of the drug development and other pharmacokinetics things? And then they have used it in a reverse manner. Okay, now we have found this. So this was not primarily, see, they have no mention about how the sample size was calculated.
Yes, sir.
And so their primary aim was not to look at your differentiation of basal LH versus stimulated LH or whatever. Their aim was just, this was part of the drug development. But now you've got the data, so they're using that data to come. The problem with these studies is that they are not sized, adequately powered to assess those differences. And so this clearly is something which is going in an intuitive fashion. But then the final conclusion would be that don't go to those parameters unless you have a clinical doubt.
Unstimulated LH can be used as a surrogate marker of suppression of central precocious puberty along with clinical parameters. That is the positive correlation. With treatment, the bone age and chronological age ratio decreases and the peak adult predicted adult height improved. This is a positive correlation. And treatment of CPP and obesity, this was a negative correlation. There was a large sample size. There was excellent retention of study group patients, and they were doing a centralized assay run. And also the bone age was done randomly with double blinding. So this is the strength of the study, and the limitation that there was a small trial period. It was just only 1 year, and also they use the patient age group was only 4 to 7 years. That is also one of the limitations. And unstimulated LH has a diurnal variation which was not taken into consideration during study. And mean age of the study group was 7.5 years, and as seen, unstimulated may be higher in the older group. So inclusion of older group patient can also give a certain.
But when somebody is on GNRH treatment, you don't expect there to be high. Because you are anyway taking a review.
Thank you, sir.
Dr. Sandeep? Yeah. Yeah.
This drug is available in US.
Okay. So it's not available here at the moment, but this could be something which is available. So now we have discussed very interesting studies. One was about the role of body composition prediction with regards to insulin sensitivity, and then this novel therapy in terms of suppression of puberty with longer acting GnRH. I'll just go through a few flash newses which maybe help, and all of you can go and have a look at it. Most of them are going to come up in JCEM in the near future. These are the prospective articles which are coming, and this is something which we are always concerned, that if somebody has in vitro fertilization, whether that has an impact on the outcome of the child. Now, this study was very, very good, well-conducted study with a specific aim of the impact of high estrogen. So if you compare a IVF fertility versus a normal fertility, the major difference is they're doing a lot of stimulation to begin with. So the initial phase estrogen levels in the mothers may be very high. So what they're trying to say is that if your initial estradiol is very high, whether this results in a glucose metabolic dysfunction at 3, 6, and 10 years. This was a follow-up study. And what they really compared was that these were the normal pregnancy, then the fresh embryo transfer, and the frozen embryo transfer. So when you have a fresh transfer, you have a much higher ambient maternal estrogen because the stimulation is done there. For frozen transfer, they're just giving a 17 beta estradiol just to ensure that. So what they are finding is that children who were born to mothers who had a fresh transfer and also frozen compared to those who were normal had a higher fasting glucose, fasting insulin, HOMA-IR and HOMA-beta. Although the differences were within they don't look that much, but they were statistically significant. And of course, this means on a long run, these are younger children, their changes occurring now, they may have an impact. So what they're really suggesting is that having a high estrogen around the time of conception may not be good for the metabolic. It programs the children. So this is a very interesting concept, how estrogen can program the child's outcome. And they in fact go ahead and to say that it is necessary to avoid exposing embryo to a high estrogen environment. And they are saying if your estrogen is very high, don't do a transfer. Store the eggs and embryo, then do a later. So this is something they are trying to say, that frozen ET may be better compared to a fresh ET. And when they are doing frozen, do not give too much estrogen. Try to do a natural cycle rather than an estrogen cycle. So what they're trying to say, which makes sense, that whenever you're talking about altering physiology, be careful. Don't overdo, don't do too much estrogen. And that's why they're saying that high maternal estrogen in early pregnancy associated with risk later on. So this is something which is interesting data, which is there. They wanted to explore later on in that perspective. The other thing which we talk always about, sleep and growth. We all know that growth hormone is produced at night time, the REM sleep and NREM sleep and all those parameters. This was a very elegant study in young children. So we're talking about 1.5 years. This is the duration at 1.5 years, and what has the impact at 3 years? This was a Japanese environmental study, and you can see they looked at so many other parameters in the sense of siblings where they were there, tobacco smoking, nursery, and all those things. And if you look at the overall impact, if a child slept, and especially at night time, they were taller as compared to who did not sleep at night. And this did not include the daytime sleep. So what they really found out that sleeping is important, but nighttime sleeping is more important for these infants. And this is 1.5 years, very, very early study. So what they're saying is that importance of nighttime sleep duration, not total sleep duration. So when we say that you are sleeping for 8 hours, doesn't mean that it's good. It's the time of sleep which is also important. This was already a gender dichotomy. The females had a better benefit with that. Maybe they have a higher IGF-1 or whatever in terms of that. Male, they did not have an impact. But the overall message is that the nighttime sleep for children is very, very important as early as 1.5 years. So this is something because that's the time when the growth hormone starts to kick in terms of action. The third study was a very interesting study in which they wanted to look at mini puberty. What happens to reproductive hormones, the ovarian morphology, to uterine morphology in mini puberty, and how does mini puberty start and mini puberty end? So we know that whenever we have a child who is born, suddenly there is no inhibition which is there. And after that, the puberty starts up. And then the body realizes that, okay, now this is too early to have puberty, so it stops it. So I discussed this earlier also that humans are probably the only animals who have a childhood phase. Otherwise, they just have infancy and they then go into puberty and then they start to breed and other parameters. Now, why do we have this phase? Is basically because we want people to grow their mental development. There's so many intellectual development, and if we immediately burden them with fertility, that's going to be a difficulty. The second major hormonal adaptation which is there in humans is the menopause. Why do you think menopause is there? So why? So I said that you have a interruption of puberty after mini puberty. So mini puberty in a normal default mode would mean that, okay, you enter into puberty and then you go and have normal reproduction and everything. So that is taught because you don't want the humans to reproduce so early. You give them time to learn. If you are imposing a menopause in an older female, what advantage would that have on the human society? Just think about it. So suppose you have a young lady who has become a mother. Her mother is still pregnant. So then who is going to take care of the younger one? So this menopause is basically a way of nature of providing an additional somebody who can support the newborn. And this is important because human newborns are the most fragile overall. And that is why this concept of menopause also is something which is very, very significant from that. So coming back to the study, this looks very complicated, but what they're trying to say is that in mini puberty, you already have some concept of feedback inhibition happening. Now, why we are saying this is a problem is that because your inhibitory pathways are not there. But in mini puberty, when they correlated mainly the antral follicle count with the AMH level, with the LH level, with the FSH level, they did found that if you have more antral follicles, your FSH becomes less. So this feedback mechanism starts to mature. There's a very good correlation in those parameters. And then they give us very good reference range. So if you are now really looking at in terms of the ultrasound findings, you can go to this paper which gives you mean and SD in terms of what should be the uterine volume, the ovarian volume, the follicle count. So these are all parameters there. So this study has two important implications. One, they have given these reference ranges, which were not easily available. And what they said is that negative feedback in the female hypothalamic gonadal is established during mini puberty. So before that, there is no feedback, but this feedback starts getting established at this point of time. This is what they have shown, and they have given cutoffs for all these parameters. So that's why this paper is relevant from that perspective. Now, this one is something which we already have discussed earlier about longer acting growth hormone preparation. This is somapacitan, which is a long acting growth hormone preparation from the Novo Nordisk. This is basically derived by altering the binding of this to a albumin site, increasing its half-life. This was the real 5 data, and this has now come up in JCEM. What they found was that they compared 0.16, 0.2, 0.24 milligram per kg per week to the conventional doses of growth hormone in the initial 1 year. And then they found that 0.24 was the right dose. And then they followed this up in the SGA children. And what they really found out was that there was a good effect in terms of the increase in growth velocity as well as the height standard deviation score. So what they're saying is that once weekly, 0.24 milligram per kg would be the ideal dose as far as somapacitan is concerned. And hopefully we are going to get the SGA approval soon in terms of the availability. So we have tried to cover a lot in terms of the metabolic profile, in terms of precocious puberty, in terms of long-acting GnRH, long-acting growth hormone, and a few interesting studies. All of you can go through these articles, they are available and that will be of help. You can go and have a look at our website, our courses to explore the publications and our mobile applications in that regard. So this has been important issue that we have been discussing about. And today is the last presentation of Dr. Dhwani. So I'll invite her to, we'd like to thank her for being here for 2 years, and she is now completing her fellowship and she is leaving us. So we'll have our words as well.
Thank you, sir. These last 2 years have been, I speak like this. I've had 2 wonderful years here at Regency, and I would like to thank sir for giving me an opportunity to join and this fellowship program. I am extremely grateful to Sir Rishi Sir and Yutika Ma'am for their training throughout, and my colleagues who have been extremely important support throughout these 2 years. I would also like to thank everybody from the team MedEClasses for being so approachable and for all their visits here. It has been great interacting with all of you, and I hope to continue this association always. Thank you.
And I think I remember when Dhwani had just come, we had the practical pediatric endocrine course online, I think the first or second day or something like that, when Sayan, Vibha and everybody was there. And so at the end also we have this, so it's a good one to end up with. So I think we will close the session here and we'll